Hello and welcome to today's webinar, Care Delivery Redesign Using Health IT. Thank you for joining us. And before we get started, I want to take a moment to go over just a few administrative details. As you have noticed upon joining the webinar, everyone has been placed on mute for the presentation. At the end of the presentation, there will be a question and answer session. In your GoToMeeting control panel, you will see a questions box. Please type your questions or comments into the field and hit enter. The recording of this webinar, along with the slide deck, will be posted and emailed to all of our registrants so you can view this webinar again or share with your colleagues. Also, we've actually added the slide deck to the handout section of your GoToWebinar control panel, so you can download it now or wait until I email it to you after the live webinar. But either way, we want to make sure you've got access to that fantastic information. So without any further ado, I'd like to go ahead and hand it over to today's presenter, Adele Allison.
Thank you, Sam, and welcome everybody. Thank you for your time and joining today. Work very closely with Sam and appreciate all the hard work that she does. So welcome. More and more, the healthcare industry is really moving to value-based care. It's something we've been talking about for quite some time. And a component of value-based care is obviously the economic piece or value-based payment. And that has it impacts everything. You know, at the end of the day, that's the lifeblood of the equation, how we keep our practices open and how we keep businesses sustainable. As of the end of 2017, the Healthcare Payment Learning and Action Network, they every year in October, so last October, they track the adoption of alternative payment models, which is something we're going to talk about today. And at the end of 2017, roughly 34% of all health plans, and that's all lines of business, so that's, you know, traditional Medicare, Medicare Advantage, Medicaid, managed Medicaid. It represented 77% of the covered lives in our country. Roughly 34% of all health plans were making payments based on value through an alternative payment model. Now, it may not have been bearing risk at that time, but there's just so many IT-related dynamics to moving to this type of economic model, from the measuring of value to the paying for value. And federal and state governments have definitely fast-tracked the shift of healthcare payment from transaction to analytic-based reimbursement. So with the changing economics altering traditional health plan business models and provider care delivery models, today we're really going to explore the use of health IT as a change agent so that we can impact and actually try to achieve the long-discussed triple aim of better care, better health, and lower costs. So with that, I'm going to kick us off. The information that I have today is current as of yesterday when I reviewed the slides. So I do sometimes get into policy, so I want to make sure that you're aware of that. But what we're going to start with today is just a level set on economics and some of the mega trends that are going on. We're going to jump into the value-based payment archetypes because that has a direct ramification on what is being measured to define value. We're going to talk about managing health over managing health care, and there is a world of difference between the two. And then we're going to get into the beef of redesigning practices and payer operations using health IT so that we can truly achieve health value management, and we'll wrap up with any questions. So getting into the economics and megatrends, this is something that I put together. We're all, you know, if we've been working in healthcare for some time, you're aware of this. So we got this is looking at the government component of this. We got our government-sponsored coverage, our socialized entitlement benefits in 1965 under President Johnson. And when at the time that we created these two entitlements, the number of Americans, and I pulled data from the census as well as the last national healthcare expenditure data. So roughly 9.5% of the U.S. population was on Medicare, and we only lived to about 68.2. So meant the government really was only going to carry water on you for about 3 years. And the number of Americans that were on the Medicaid program was only 2% of the population. And of course, we didn't have the Children's Health Insurance Plan. Looking at the last data, and there's always about a 2-year lag with the CMS data, but as of 2017, those populations have certainly grown. And we also have the CHIP program now. But the big thing is the cost of healthcare in our country. That has really gone from 5.6 cents. So when you look at this economic marker, think of it this way: as a percent of GDP. If I spent $1 in the U.S., how much of it would go to housing, food, transportation, or in this case, healthcare? So in 1965, 5.6 cents of every dollar spent was spent on something healthcare related. This is where we were as of 2017, and I know that based on CBO reports and things that I've read, we actually tipped over 18% last year. The projection 10 years out is this is where we will be, and the number of Americans that will be on a government-sponsored program is pretty significant. Now, there are some disruptors we have to watch: Medicare for All, Walmart getting in the health insurance business. I mean, there's some big game changers that certainly could disrupt this trajectory. But essentially, we're looking at about a 50-year span from when we created these programs. And you can see by the time we get about 10 years out, just about 50% of Americans, closing in on 50% of Americans, will be on a government-sponsored program. So this is a very interesting trend to me. So if we look at these two programs, so we have our traditional Medicare Parts A and B, and this is being impacted by a bipartisan bicameral law called MACRA. It was enacted in 2015, had sweeping positive support on both sides of the aisle, both houses of Congress, which does not happen very often. Now, when we look at Medicare enrollment, it is booming. The baby boomers, my generation, we started hitting Medicare eligibility in 2011. We had 4.8 million boomers enroll in Medicare, and that trend continues for 20 years at a rate of 2.8 million per year. And so we've seen this huge growth in the number of Americans coming on to the Medicare program, and it's just not a sustainable trajectory from a cost perspective. The privatized Medicare program, which is Medicare Advantage Part C, the enrollment has tripled since 2004, and this is really tells us a couple of things. Number one, baby boomers are going towards the privatized Medicare program, and, you know, we're seeing quite a growth. So while it's government sponsored, it is we're seeing all the growth take place in the private industry, or a lot of that growth take place in the private industry. So plans have to bid each year to offer these privatized Medicare plans. They get capitated. Many of you are part of these health plans, so I'm not going to dive into this too much. But one of the things that they get measured on is quality. And so, again, getting value for the dollar is something we always try to strive for. So it doesn't matter if I'm buying a car, a house, or healthcare, I want value for the dollar. And this is measured in the form of stars on a 5-star scale. So plans receiving 4 or more stars in their quality measures, they get a significant bonus. So this is a big, achieving that value status is a big deal to a Medicare Advantage health plan. Some of the mega trends that are going on in this particular market trend is they're expecting or predicting Medicare enrollment will reach 50% of where it's 35% right now, about 50% of all the Medicare lives by 2025. And really, that seems like that's way out there, but I can't believe we're we're in May of 2019. That blows my mind. The other thing that's very interesting is that if you look at United Healthcare, Humana, and the Blue Cross affiliates, they account for almost 60% of that Medicare Advantage enrollment. You have a lot of people who are getting into these plans. A lot of them are provider sponsored, but the ones who really hold the market share are these three these three insurers. They have the government allows for them to have flexibility in how they reimburse. They get to dictate what their contractual relationships with a provider looks like. But we're seeing a changing competencies and this expectation that's coming from being driven by what's expected from the patients. They want the value for the dollar. Star ratings, we already kind of touched on that. It's a big differentiator in addition to driving revenue. Industry concentration and these payer-provider collaborative models are growing. And MA plans now, even if they're not getting into value-based care, they're being impacted by value-based care for parts A and B by MACRA. If they have a non-par provider who is due a bonus, they can decide whether they want to, do a take back. But if they're eligible for a bonus and they are a non-par, those MA plans have to pay those bonus dollars. So this is impacting their operations more and more. Looking at Medicaid and your privatized Medicaid, these are jointly administered by state and U.S. governments. Just some trends, we're closing in on 80 million Americans. And just to kind of give you perspective, and this is where I go, every other person is on a government plan, we have about 325 million people population-wise in our country. So 80 million is a pretty big chunk. It represents 21% of the covered lives in our country. Very high on the maternity end. It represents 18% of the total spend, and that is growing, especially since we have expanded eligibility for the Medicaid program. And the federal government may not control it, but they contribute sometimes as much as 2/3 of the money to fund and pay for the Medicare expenditures. Some of the mega trends in the Medicaid market, you've now got 28 states, DC, that deliver or have privatized Medicaid to private organizations, and it represents about 75% of the Medicaid enrollees. According to a report that was put out by Change Healthcare, we now have 46 states, the district, and Puerto Rico who are doing value-based payment. And 20 states are mandating performance or value-based or bundles. It just is all over the books. And when I look at policy, and that's my job, I have to keep up with all the policy and read this stuff. Federal is easy. It's a one-size-fits-all. So I analogize that to the Cleaver family. It's maybe we have our problems, but it's the same whether you're in my home state of Alabama or whether you're in Talkeetna, Alaska, or New York City, New York. It doesn't matter. The policy is the same for Medicare. When we get into Medicaid, I analogize that to Married with Children. It's a little more frantic. And it's the same for your private industry. The wide variance, and so if you're a payer and you play in multiple states and you offer commercial products, you offer individual products, you offer Medicaid products, the requirements are so widely variable. And just to kind of give you an example of this is just a sampling of some of the states that are out there and what they're doing, and a couple I'll point out here. Ohio, very prescriptive in their value-based payment. So Ohio Medicaid is saying you will do bundles, you will do these bundles. This is the criteria. This is the what's included and excluded, and we're going to tell you how many of the claims fit into that bundle, and we're going to give it to you, and you have to pay it out. Very, very controlled and prescripted in Ohio. But then you'll get to a state like Texas, and they have 22 managed care organizations, and it's let us out and flowers bloom. We really don't care what your model looks like, MCO, but you have to hit a certain percentage of your payments have to be paid through that model, and it grows. So by 2021, we don't really we're not telling you what model to use, but at least 50% of your payments have to be tied to some type of value-based care. And so it's just very schizophrenic when it comes to states, and that would be the same for commercial. So the federal response to spending and the cost and trying to do cost containment, there's three things that they're trying to achieve in policy. One is change the way we deliver care from episodic, I treat the patient when they have a heart attack, or to one that is proactive and involves the patient. So I manage the diabetic patient so they don't have a heart attack at all. And then also the payment. We want to, instead of just purchasing a service, we want to purchase a value, which means we have to define value. And this is where data and technology really, that's the big level setter. So we want to take the data when we define value. We want it ready when and wherever we need it. We want to distribute it widely, and most recently in some of the interop rules, we want patients to have access to their data, and we want to be able to move that data interoperably. So if we look at data in healthcare, the most pervasive and ubiquitous data we have is claims data. So if we think about the claim, I have obvious data points. You have your demographics, you have the codified, object-oriented, machine-readable answer to two questions. What did you do? I answer that with a procedure code, and why did you do it? And I answer that with an ICD code. And they need to make sense, right? So I may put in E11.8, which tells me, doesn't matter what payer I'm with, what provider office I'm with, all systems know that that code means I've classified the patient as a diabetic, and that tells me something. I'm going to spend more on that patient than a non-diabetic, right? But it doesn't tell me what their blood pressure was, their last A1C, their BMI, those factors that really tell me what's going to happen with the health of this diabetic patient. That requires clinical data. So under President Bush, we established the quality reporting initiatives, both on the hospital and the physician side, so send us your data. Initially, it was voluntary. It became permanent. And those programs then evolved into pay for reporting. The biggest pay for reporting program the federal government had was meaningful use. I'm going to pay you to put the infrastructure in to capture the data, but then I want you to report these electronic quality measures to me. And it doesn't matter what they say, just get the data to me. What we're hitting now is I can now start to converge administrative claims data with clinical information. And value will always be a function of quality and efficiency. So if I'm only doing one or the other side of the equation, I'm not doing value-based. It has to have both components. And I'm better able to establish that with more data. Now, under the Medicare Access and CHIP Reauthorization Act, for the federally controlled programs, parts A and B, really B is what we're looking at, but as they get into alternative payment models that impacts Part A, I will pay you one of two ways. I'll either pay you differentially through the Medicare, the Merit-Based Incentive Payment System, MIPS, or I will pay you across the care continuum for a shared patient, but you have to be bearing downside financial risk. And this will lead to affordable quality health care for all Americans. This is our trajectory, and I'm not going to go into it today, but I like to call the laws that make up this trajectory the HIPAA-MIPA-TRICA-ARA-PACA-MACRA era. It is just enormous, and we hear bits and pieces, and it's very difficult to figure out how to put that together. Essentially, there are three federal policy aims. We want to move Medicare payment into value-based, and this started this year under MACRA. So we're going to pay for value instead of paying for a service. The other thing that they're really doing in policy right now is trying to ease the burden on provider and ease provider abrasion. Everybody hates change. And I live in Alabama, as I told you, and our state motto is thank God for Mississippi, because we hate change. We'd literally rather have a rash over 70% of our bodies than do it differently than the way we've always done it. And so all this change that you're putting on top of me, blended with the hypnometric or alpaca-macra era that I don't understand, really causes a lot of resistance, abrasion, and does not make change easy. So we really want to ease that. The other big thing that is missing in this equation that we've been trying to achieve for well over a decade is we want data liquidity. So when we look at the things that we're trying to achieve from a federal policy perspective, they're all linked to health IT. We want everything to be data-driven payment, data simplification, and data liquidity. So it's data, data, data. So that's really what we're getting into digital health. And if we do a look back over the past 50 years of where healthcare has come from in a digital perspective, and it accelerates as we get going, but I'll just point out a few things here. Our relational databases that, really gives us the flexibility in programming. Those were developed in the 70s. And I'm a real old fart, so I remember some of this stuff, but I remember MS-DOS with the little caret prompt, usually an orange or green screen. DRGs, diagnostic-related groupers, something that hit hospitals in the 80s. Home glucose meter, that was a big thing. And MRIs, I mean, come on, that's care delivery as well, but it's digital, right? We're getting into technology. As we get into the 1990s, you had the wrist blood pressure cuff, which is wonderful. This is when we got HIPAA, which was policy that made Herculean change from the claims perspective. Before that, everybody was printing their claims, had their labels, shoved them in an envelope. They got mailed, actually keyed in physically into the payment system. Crazy stuff. I don't know if you remember PDAs. That was the big thing. We didn't have our smartphones at that point, but we had our PDAs. We mapped the Human Genome in 2000. This is when Jobs came out with the iPhone, and the iPad actually hit at that time, and it was transformative to the market. Google, this was one thing that was very interesting because of the amounts of data Google had. They were able to report swine flu before the CDC. That was a big thing. We also got the Fitbit, came out in the early 2000s, and e-prescribing became mandated by the federal government, and it's now at 85% adoption rate. Coming into the 2010s, which is the decade we're closing now, you have virtual digital health investments of $11 billion in last year alone. 50% of Americans have wearable technology. We had automation of the clinical side of the house. You had the Affordable Care Act, telemedicine, telehealth, Uber Health. AI is a big thing, and machine learning, and it just goes on and on. So this really creates an opportunity for disruption in our healthcare system. And innovation is wonderful, but imagine when the first cars came out, it disrupted the industry for those that worked with horses and carriages and buggy whips and all of that. So technology can be very disruptive, and the goal here is to be the disruptor, not to be disrupted. And, I don't know how many of you remember paper maps, but I do. I remember them really well, and now I can't get anywhere without my GPS. And one of the big disruptors that they use as an example is self-driving cars. It's something you hear about here and there, depending on what you read on the internet, but it's going to disrupt parking, law enforcement, car insurance, lawsuits, auto repairs, or even saying it could be disruptive to hotels because they could have driving vehicles that are have a bed in them, or a conference room. So as you go across the country in your self-driving car, you're holding your meetings, or you're like in a hotel room. So if we apply this in a futurist view to healthcare, this might be some of what would go on. I let's say that I leave Alabama, I go to the Northwest Pacific, which is one of my favorite parts of the country, or I know I've got some people from Tennessee. I go up to the Smoky Mountains. So I'm in the Smoky Mountains and I'm hiking away. I'm short of breath because I'm a fat old woman. And my Apple Watch tells me that my blood pressure is high. Miri, meanwhile, says, oh, you need to go see your doctor. Your blood pressure is really, really high. So I start to get worried because I start to feel this heaviness and everything else. So I end up going to a hospital there in the remote area that I am. It's a smaller hospital. And using an Apple Health app, they're able to get my medical records, not just my claims data like they're talking about with the proposed rule, but they're able to get all my information so that they can better take care of me. The medical team at that hospital then contacts my doctor through telemedicine. And they have this conversation. He knows me. They're getting to know me. And they decide I have to have immediate heart surgery. But there's no center of excellence in this somewhere USA that I happen to be. So they actually schedule me for surgery, which is done through telesurgery by a doctor out of Cleveland Clinic. At the end of the day, I'm all fixed. I'm in great shape. They send me home on these, this new litany of medications, and the drugs were produced and researched by Google. And my PCP then maintains and follows me remotely through social media and other types of applications. So digital health hitting healthcare could have huge ramifications in when we think of value-based care. So let's come back to where we are now. So there are essentially 4 categories of value-based payment, and this is getting into the economic equation. Think of it this way. If I have a contract, I'm a payer, and I have a contract with the provider, and they accept my fee schedule. If there's a benefit and they perform the service, I pay them based on the fee schedule. No link to anything else. Just, did you do the chest x-ray? Yes, here's your money. That is a Category 1 contractual arrangement. If, however, I am adjusting that payment based on measures of quality or because you did something like put infrastructure into place, you became a medical home, you did meaningful use, or you reported data, but certainly performance-based measurements, pay for performance, then this is a Category 2 contractual relationship. As I begin to contract across the care continuum, so things like shared savings with an ACO may not have downside to begin with, but ultimately that's where we want to get to. It still could be retrospective. I've got a total cost of care that I'm expecting on Adele Allison when I give her to you, and I'm going to reconcile back the actual spend to my projected spend and look at quality measures and adjust accordingly. This also in this would be procedure-based episodes of care. So that would be like knee replacement, hip replacement, things of that nature. Category 4 is population-based payment. So I've been in healthcare a long time. This is capitation. I give you the patient, I give you the dollars for the patient. Could be condition-specific. I define the services. Could be comprehensive population-based payment. But this is ultimate risk is what we're talking about here. So obviously the risk side of the equation coming to the providers is on these types of contractual arrangements, and non-risk is on the are on the categories 1 and 2. So looking at the archetypes of these, on the outpatient, we're familiar with these types, right? It's traditional fee schedules. I'm paying on a percent of Medicare, and inpatient per diems, DRGs, case rates. Operationally, there's nothing simple about doing a Category 1 contract. Sounds simple, but it is far from simple. You still have things like formulary. You still have STARS, HEDIS, quality reporting that has to happen, risk management. You still need pricers for those nuances in provider contracts. So there's really nothing simple about it, but let's say it's less complex than the other type of architecture. So as I move to Category 2, it's still a productivity form of payment. I could be paying for infrastructure, I could be paying based on performance, or I could be setting up a program that I want them to, like, behavioral health integration into primary care. But where I'm paying an incentive or a bonus or differentially adjusting to the positive or the negative, like they're doing under the merit-based incentive payment system under MACRA, these are Category 2 archetypes of payment. We get into 3 and 4, and the most common types that we see here are shared savings, which may or may not have upside or downside financial risk. You have to be able to do total cost of care calculations. You have to be able to do patient attribution. You have to be able to risk adjust, as appropriately or as appropriately as possible. And you always have to measure quality in all of these. As we get into episode payments, is it going to be retrospective? I'm going to pay them their claims and then reconcile back to a bundled payment, or is it going to be prospective payment? Am I doing an episode payment for a procedure or a condition? What is the spend that we agree upon? And are there certain carve-outs that could be types of patients, services, providers? All these business logic rules have to be built in. And then, of course, population-based payment. This is capitation. Now, in California, where capitation has known a full and fruitful life since the mid-90s, this may not be as much of a stretch. But in Alabama, population-based payment is going to be a pretty big cultural shift on both the payer and provider side, and it requires different systems. They also introduced 2 new Category 4 models, CMS did, that are coming out of the Innovation Center. So these are capitated models. The first one is called Primary Care First, and it's kind of the next iteration in the comprehensive primary care model, which was then, that was 1.0. 2.0 was Primary Care Plus, and then 3.0 is this Primary Care First. These are multi-payer arrangements under the Innovation Center, and they're being launched in 26 different regions. So there's 2 models. This one's the primary model. It is a 50% upside, 10% downside performance-based capitation. So they give the capitation, but then they do adjustments. They have to be able to provide advanced primary care, and there is some performance transparency or data sharing that's going on here. They can include complex, chronic, or seriously ill patients. Their goal with this model is to reduce the total cost of care as well as acute hospital utilization. The second model that they've introduced, these just came out, I think they were announced on April 22nd, is I don't, want to take normal primary care. I just want the sick, seriously ill population, the SIP part of the population, because I practice hospital or palliative care. This is capitation with differential adjustment based on performance. So these are 2 primary care models that have just come out of the Innovation Center, but they are multi-payer. This is where they're working with other payers in these regions to make this happen. Now, they're expecting to launch these. I think the bid process to sign up for these is going on. So these are value-based care and payment delivery models. But January 2020 is when they're planning on launching these. The other one that's real interesting is what they call direct contracting. And these 2 are Category 4 models. And if you look at the date, this is because there's some things that have to happen in order to get there. But imagine this. I work for ABC academic world-class institution, and we just created an MA plan, and now CMS is going to do direct contracting with the provider. So they're basically going to compete with me. They're going to take those people away. This is really looking at next generation accountable care organization and risk-bearing MA providers. And so this could be disruptive to your MA plans and something we want to keep a real close eye on. But there's 3 models. This third model, they've issued an RFI, so they're looking for additional information. So this hasn't really come out. But models 1 and 2 are definitely something they're working towards. This is professional PBP, population-based payment, capitation. It is a PCP capitated model with 50% risk sharing, risk-adjusted patients, and enhanced PCP services. The second model is global capitation. So this would, be 100% capitation. It's PCP capitation or total cost of care capitation. And the providers in these have to have a common governance structure. So this is where they're getting into next generation ACOs. And then, like I said, this capitation model would be geographically defined, and it's total cost of care for parts A and B, defined by a region. Now, in doing this, there has to be a minimum of 75,000 patients. This is what they're proposing. They're asking for information on. And the getting into these, one of the things that CMS is looking to do is reduce the spend by 3 to 5%. So when I do total cost of care, if it's $100, my bid will be for $100 less 3 to 5%. That would be my capitation rate. And they are really they're looking to launch this one in 4 regions. It's a 5-year contract in January 2021, and they really want 2 entities per region kind of as their minimum threshold. So that's one that they're getting into as well. So I've spent some money going through a lot of stuff very quickly. I want to talk a little bit about what all this means and what's coming about. And so when we look at digital health, technology impacting things, when we look at our current health system, this is kind of where we are, and this is ideally where we want to get to. This is something that came out of Johns Hopkins Applied Physics Lab. There was an article. I've got all the links in here, and I think the presentation is attached here. But if we look at or think about what we've got here in looking at it through an economic lens, your cost is when you treat and detect. So, I detect there's costs associated with that. I do a mammogram, I do a colonoscopy, I do an MRI, and then I treat. So this is all kind of your cost. So if my current health system is really here, we're still practicing episodic care delivery. As I try to get into my ideal health system, and this is where there has to be a convergence or an alignment between the payers and the providers, I need to be able to take populations of patients and do predictive, and I would even say prescriptive analytics, making certain behaviors happen, and then focus on preventing. And if we do this, then the number, detect and treat, this should come down. And this is really looking at digital enablement. Some of the technologies that are coming out are telemedicine. And by the way, we have a work group at WEDI on this. So be aware that we have some things that you may want, if this is an area you're interested in, come to WEDI, join these work groups, get engaged in the conversation. API integration. This is huge. The rule that came out on Interop came out, it's companion rules, CMS and the Office of National Coordinator. This is a big one. There's going to be a lot of talking about this at our spring conference. Again, get engaged with WEDI. These are things we're actively looking at. Remote monitoring, artificial intelligence, predictive and prescriptive modeling, surveillance. These are just, this is not an exhaustive list, but tech enablement is what is going to get us over here. Now, there are barriers to this that we have to cross. If I could have the greatest thing in the world, but if I'm expecting a doctor to use it and they've got to get out of one system, log on to another system, search for a patient, they'll never use it. And so we've got to make it usable. It's got to be something that integrates naturally to a workflow. We also are still facing right now this barrier to freeing up our data and integrating systems. And then what we do in a demonstration may not actually be what plays out in the real world. Our country is so diverse. If I'm looking at a patient in California versus New York versus Bayou La Battery, Alabama, I guarantee you the belief systems are different, the cultures are different. So what worked in a study in New York City may not work at all in Bayou La Battery, Alabama. So there are some hurdles that we have to work through to make this happen. But it is about managing populations proactively. So we have a distributed population. Now, as a health plan, this is my enrollees. These are the people that I enroll into my plan. As we get into these alternative payment models, these are patients the plan says, this person, Adele, is your responsibility. So you have attributed populations, and the first thing I want to know is how sick are they, or how healthy are they? Let's go positive. If they are a healthy person, I'm likely to not have to spend as much money as if they have comorbidities and chronic conditions and things of that nature. So this is where we get into the health assessment of the patient population. Then we want to stratify that risk. There's going to be some patients in that risk that are low or no risk, some that are moderate, and some that are high. So depending on how those patients stratify, we then want to intervene with the intensity of the intervention growing as they become higher and higher risk. So let's look at this from a systems perspective. I got to know who these population people are. I also need to know what their status, their health status is. I need to know where they are on risk stratification, and I got to figure out how I'm going to intervene. And we want to translate this to automation, digital health as much as possible. So essentially, you're going the full range from population-centric controls down to individual-centric controls. The way that I message a diabetic who has metabolic disorder because they just like to eat and they're lazy versus someone who has a genetic predisposition for it would be very different. So you got to translate that down to the individual level. And this is, easier said than done. So when we talk about digital disruption, where we are right now as a country, generally speaking, is we manage healthcare. This is what we look at. We look at cost containment, and we're trying to make that shift. This is resource-based management of healthcare. Where we want to get to is managing health. And this model, I can't take credit for it. It's something I've been preaching for a long time, but this is actually something that was coined by Gartner Group, health value management organizations. But I want to get to the outcome. And the outcome is not necessarily about managing resources because patients are different. But as that risk shifts from the plan to the provider based on the contractual relationship I have, my monetary prospect here is health, not managing health care. And when we look at what's going on with MACRA, MIPS, the Merit-Based Incentive Payment System, and their advanced alternative payment models are clearly trying to move people in this direction as well. And we've seen this again and again in legislation, HIPAA, or the Balanced Budget Act, RBRVS. I mean, I could just list out where the government has gone in and done something and everybody else follows suit. So this is definitely where it's going. So how do we redesign using health IT? Well, let's start with the quality equation. So it's not just about cost, it's also about quality. I'm not going to go into a long spiel of this because of time constraints, but the genesis of measuring quality really came about at the turn of the 21st century. And what it resulted in was CMS establishing 6 national quality strategy domains. And if we kind of break these down, something appears here. If we look at these domain areas, you're looking at lower cost, better care, and better health. Well, what is that? Hey, that's the triple aim. So using the triple aim as our 3 guiding principles, that's what we always want to kind of tie things back to as we think about redesign and re-engineering of processes. So I thought the best way to do this was to actually walk through a persona. So meet Nancy. Nancy is a 51-year-old American. She's actually a New Yorker, and she's got rheumatoid arthritis. She goes to the emergency room lately. She's been going every month because she has such bad joint pain and it's not well controlled. Her data shows that she has 4 unique providers, and she sees a different emergency room doctor every time she goes. But she has a family practitioner, a rheumatologist, a cardiologist, and a hematologist. Her RA is very poorly managed. She has a lot of other things that are going on, and she's very much at risk for increased cardiovascular disease, which is something that's common with RA patients. If we look at Nancy's complexity profile, look at this litany of problems that she has. Not the least of which is not just physical ailments. We also have some mental health problems here. Looking at her utilization, she's had 20 office visits in the past 12 months and 6 ER visits, 3 hospital admissions. It's not going to be hard for me to figure out this is a risky patient. So whether I'm getting this patient through enrollment or I'm getting this patient through attribution, this is someone I should have the technology to flag. She's on a litany of medications. She's also had a lot of, pretty significant surgeries, joint replacement, arthroplasty. I mean, just it goes on and on and on. So what we're going to do is we're going to look at the traditional transaction-based payment model that exists and is prevalent in our marketplace. So the way this works is the patient goes and sees the provider files a claim, the payer bumps that up against a fee schedule, prices the claim, it hits the core claim system, and a payment is made. Now, I have way oversimplified this, but just for sake of just talking about infrastructure, from the provider side, looking at it from the lens of the provider, they've got to have a practice management system, revenue cycle management. They also are, at this point, likely using an electronic health record systems, and they may have clinical systems like a lab information system, a digital PAC system, an electronic EKG system. They may have all kinds of technology that are clinical in nature. On the payer side, we have to be able to enroll, do eligibility, and bill our members. We have a core administrative system. We have to be able to stratify that risk and perform adjustments, on payments. We also have to do compliance reporting, especially if you're involved in government-sponsored programs. So this is quite complex, even where we are now. So let's just walk through traditional payment, and our focus is not on managing health, but managing health care. So my member says, here I am, I'm Nancy, I'm moving less and less, my RA is really getting in the way, I've got increased joint pain, I'm running out of sick days, I have to work, I'm a single woman, a divorcee, and I've got to go work tomorrow and I can barely move. So what do? I go to the emergency room for relief. This is my 6th trip to the ER in 6 months. And each time I go, I have a different emergency room doctor. There's no I haven't seen a primary care in 12 months, so I definitely don't have a medical home. My RA is obviously getting worse. So what do they do at the emergency room? They give me a 5-day opioid supply. They discharge me and tell me to follow up with my PCP. So that's essentially what I've got in this. So I'm definitely not getting better care, looking at my guiding principles. What is that leading to better health? Well, I've got inappropriate pain management, puts me at risk for opioid addiction. I don't have a medical home. We're only reacting to my symptoms. And I certainly, may be happy for the day, but it's not giving me any long-term plan or relief or hope. So I would say I don't have better health. Let's look at the cost. The average ER cost is around $1,200. And even if I was still doing episodic but went to an urgent care, it's $155. So the 6 ER visits, they're giving me poor care, not helping my health, and they've cost me over almost $7,400. So we're not hitting it on the cost there. So let's continue on with our persona here. So I go to see my rheumatologist. Post-visit, they put me on medications, but post-visit, I have increased chest pain. I had gone to a heart doctor that I got the name of from my cousin because I don't have a directory for my health plan, so I don't know if they're inpatient or not, but she swears they're just lovely at the bedside. So, but I haven't been back to see that heart doctor in 10 months. And here I'm having this chest pain, but I can't keep being sick from work. So what do? Back to the emergency room. So the cardiologist is out of network, which is high cost, but I go to the ER for chest pain. Lo and behold, they say, you're having a heart attack. So they admit me. The cause of the AMI is that I have chronic inflammation due to the poorly controlled rheumatoid arthritis, because that's what it does. It inflames everything. So they admit me, they stabilize me, and they put me on high-dose oral steroids, and there's no follow-up visit. They tell me again that I need to follow up with my doctor, but they don't schedule anything, and I got to get to work. So where are we on the health scheme? Well, we could have avoided the heart attack if I'd been well controlled and my rheumatologist had been on their game. I now have heart damage, and of course I'm getting more and more depressed and anxious with what's going on, so I'm not hitting it there. And where are we on cost? Well, if we had been well managed and not had the heart attack, I would have saved almost $40,000 on the cost, so we're certainly not hitting it there. Continuing on with our persona, I feel worse after my hospitalization. Gosh, it must be from the heart attack that I had, that I've got this dry mouth and I'm constantly going to the bathroom. So where do I go? Back to the emergency room. Boy, does my life stink. What goes on? Well, they find out that my blood sugar is off the charts. I'm in the 500s, and that is acute onset diabetes related to the drugs that they put me on, the high-dose steroids. So I'm readmitted for care. It hasn't even been 30 days, just because I have all these comorbidities going on, and I'm discharged once they get my glucose level normalized. This is not good care. What's going on with my health? Well, we could have avoided the ER visit, the readmission. Again, I've got declining health, from these acute episodes, and of course, it increases my depression and anxiety, so I'm not hitting it there. And then we have the costs associated with all this care and treatment, which is another $32,000. So my total unnecessary costs using the management of resources is $78,000, almost $79,000. This is not a good way to manage, Nancy. So let's re-engineer or redesign using health value management, where we're going to really do some provider network management. We're going to align with the providers. We're also going to do some risk and quality management. We're going to apply some healthcare economics and really make sure that care coordination is happening. So we're going to put this stuff into play, and we're going to start with an analytic-based payment system. Now, these are additive systems to the ones that we just talked about. So the patient, when they go in this type of environment, they go to a community of providers. And those providers are also being attributed populations of patients. Now, they submit claims to the payers, just like they've always done, but they also have analytics that they're examining on these attributed populations. So they're submitting data to the payers. It goes beyond the data on a claim. The payer has advanced analytics as well, and they may actually be blending those analytics with other data types, like social determinants of health. Is Nancy in a food desert? Are there transportation issues, education and health literacy issues? Then we also, based on the contract, we have to accumulate the right kinds of claims associated with our payment agreement with those populations, price out the care, tell the claim system how to pay the providers. But what I also want to do is share data back. So what we've got going on here is new systems. So on the provider side, again, additive to what we had, we want them to have population health management, advanced analytics. They need clinical decision support. So if the patient comes in to see them for something unrelated, it's giving me alerts for care gaps. Interoperability, that's the big piece that's missing here to make the data flow between the two. On the payer side, you need to be able to do a member-to-provider attribution and track that. Advanced analytics, measuring and tracking, tracking and provider feedback, payment reconciliation, You need to be able to administer the APM, and again, interoperability impacts all of that. So we've got all these new designs that we're putting into place. So let's go see Nancy again. Well, before we even get started with our contract, with Nancy, we have contracted as a payer with an integrated finance and delivery system. That's what's going on here. And we're doing comprehensive population-based payment, which is category 4. Now, we're going to risk adjust using our own and shared data that comes from the IFDS that they get through health risk assessment. We take that information, so this is going to help us lower costs from a positioning. Now, all the providers are part of this integrated finance and delivery system. The PCP has medical home status, which means I know they're going to engage the patient, and they update the health risk assessment, so it's not just the information on enrollment. And they identify pain and depression on Nancy. The health plan has also used their predictive and advanced analytics to get a relative risk score to identify the problem and look at care density. What are the referral patterns with all the providers that are part of this delivery system, and what's their network leakage? They align with the providers, and they develop a care plan that's proactive, mapping it out, and look at care coordination as a care team collaboratively. So this is definitely going to lead to better care. So Nancy gets contacted by her PCP, and the PCP says, Nancy, come into the office. We've got this care plan. We've looked at your information, and we want to we want to put you on a better track. So an appointment is made with the medical home. She gets established, and she also appointments are made with an in-network rheumatologist, cardiologist, and dietitian, because we think that's part of the care team. Wow, Nancy's blown away. Her plan and her providers must really care about her. This is how you get a patient or a member for life. What does this lead to from a health perspective? Well, she's referred to the rheumatologists and cardiologists that are in network. She's put on medication to help with her identified depression. They also do medication reconciliation, and it's available for all the doctors so they know what she's on. So this is definitely going to lead to better health. From a cost perspective, there is a cost associated with doing this, and we estimate that would be at around $16,400. So let's continue on. So better care. The PCP gets a summary of the care record after they meet with Nancy, and they send it to the rheumatologist through an open API. The rheumatologist does a meds reconciliation and is EHR, and he initiates DMARD therapy using methotrexate. He updates the care record, sends it back to the PCP, and everybody funnels the health plan to the payer. So, funnels all the information to the payer, so they have a longitudinal view for their advanced analytics and everything that they have, the view that they have that goes beyond even their system. That leads to better care which also leads to better health, because she has an ongoing rheumatoid arthritis care plan established. Her PCP has up-to-date records. Treatment has been and her disease has been explained to her, so she understands. And they come up with a plan for her pain control, which means her risk for becoming opioid addicted is reduced. So this is better health. And what have we done on cost? Well, the annual cost, there's a cost for doing this methotrexate, and that's around $6,700. However, because we're staying on top of her pain, she's not going to the ER. So we've eliminated the ER visit cost. So that's the cost savings. Now, what's going on with Nancy? I finally have hope that I'm going to have a pain-free life. I'm going to be able to go to work, which means I'll have a reduction in sick days. And wow, I just didn't know that RA was going to be this could be, this important and this big in my life. Continuing on, the PCP has a summary of the care record that they deliver to the cardiologist through an open API. They also schedule an appointment to the dietitian so that they can start looking at her eating habits. The cardiologist starts her on a statin, but only after because they see the drugs that the rheumatologist has her on, and that's only after that there has been conversation that's been going on there. The plan shares formulary, but the formulary includes the patient's copay, tiers on the drugs, and drug cost transparency so that they can do better management of the population. So we're definitely getting better care there. So her cardiovascular risk is reduced. Her diet shifts to heart-healthy foods. She's started to exercise. She's definitely having a decrease in depression and anxiety, and better understands how to take care of herself. So we've got better health, and where are we on cost? Performance data is being shared between the plans and providers. They're all on the same page. And because we've improved her cardiac status, she never has a heart attack. So that and the readmission from the cardiac drugs for the high blood sugars never happens, which saves about $71,000. So the overall net savings is $55,000. Mary, on the other hand, is feeling so much better, feeling stronger, feeling like she has better control of her life. Her loyalty towards her health plan and providers is very high, and she is highly satisfied. Looking at the economics overall, the costs associated with traditional, like I said, coming up to $80,000. As we redesign, there are costs associated with the redesign, but we avoided a lot of costs, netting a savings of $55,000. So definitely looking at those guiding principles, integrating those technologies can lead to a happier and healthy patient population, and that's really where we want to get to. Now, again, I know I'm at the top of the hour, and it was a lot of information. Please join us. We have all kinds of work groups that are exploring a lot of these technologies. This is a great way for you to become engaged. I've got ICD-10 here, but I know we're actually talking about ICD-11, so you might want to also look at that. My group is the Payment Models group. Whoop, whoop. We need talent. So if you've got knowledge on APMs, knowledge on X12 or FHIR standards or any of that, I would love to have you as part of my group. We have 5 remaining webinars right now posted for 2019. I spoke with Sam. I think that number is going to climb. The next webinar is on healthcare trends. It's on May 14th. We have our spring conference coming up. I will be there. I'm speaking. And we also have a summer forum coming up where we're going to talk about open APIs, which is one of the technologies I just got done talking about. So, Sam, at this point, I'm going to shut up and turn it back over to you.
Thank you so much, Adele. And if anybody has any questions, please feel free to type them in, or I know since we're at 4:02 Eastern Time, you can also just email me the questions. I have Adele's email address absolutely memorized by heart, so you can email me the questions, and I'll make sure she gets them and get you back a response. But thank you, everybody, for participating today, and thank you, Adele. This has been fantastic and so much great information. So hope everybody enjoys the rest of your week, and I hope I'll see you in 2 weeks at our spring conference. Feel free to email me if you'd like some more information on that as well. So thanks, everybody, and have a great day.